Hello, good afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant Khandeparkar, welcome you to this webinar on PPH management then and now. Doctor, as you know, at Hetero, we market several products in multiple therapy areas like gynecology, dermatology, pulmonology, orthopedics, and gastroenterology. With a very strong R&D background, we try to develop products keeping patient benefit in mind. Our endeavor is always to improve patient compliance because we believe that improving patient compliance ultimately leads to better clinical outcome. We have developed patches for NSAIDs, reverse treatment patches for improving patient compliance. At Frenza, gynecology, obstetrics, and IVF is an important therapy segment for us. Apart from oral tablets like Didropal and Mylotin, we market products for vaginal health. Like Feminora and Penetra. Recently, we have introduced a vaginal film under the brand name Celora. Doctor, we have now introduced Carbetocin under the brand name Carbiact. Carbetocin, as we know, is a uterotonic and is used in case of prophylaxis of PPH. To speak more about prophylaxis of PPH and the condition and benefit of Carbetocin, we have Dr. Preeti Poghe Bharude today with us. Madam is MBBS, DGO, MRCOG, FMAS with fellowship in ART. Importantly, Madam is mentor for gynecology during MRCOG. Is qualified gynecologist trained in IVF, trained in emergency obstetrics and high-risk pregnancy management. Madam has presented in several conferences, MOGS 2009, 2010, AMOGS 2011, IUI and NSV, a postpartum IUCD workshop in BMC, Mumbai. Madam, once again, welcome to you. Over to you.
Thank you very much for inviting me for this wonderful session. I hope by the end of this session, we can make out why Carbetocin is now becoming an important part of PPH management and why it is coming over Oxytocin. So we'll start with the presentation. I'll just share my slides. So can you all see my slide?
Yes, ma'am.
Okay. So let us see why it is said that Carbetocin is the smarter, superior, and a safer choice in PPH management. So we all know that postpartum hemorrhage is a nightmare for obstetrician, isn't it? And all the obstetricians, they are afraid of this word only because it is associated with a lot of mortality cases, right? And this is something which needs to be covered and cured in time. So it is such an emergency that even if you lose a few minutes in the initial part of your management, you may even end up losing the patient, right? So as we all know, it is a leading cause which causes around 35% of all the maternal deaths. Again, MMR in the developing countries was 240 per 1 lakh, that is 100,000 live births, compared to 16 in developed countries. Now, it has been seen that in India, around 38% of the maternal deaths are due to postpartum hemorrhage, and 25.7% of the global deaths, they take place in India, and 2/3 of these attribute to PPH. So that's a huge number, and that is why we should be knowing how to tackle with this PPH beforehand and to prevent PPH, what all methods, what all factors we have to look at. One is why it is really important to take care of this PPH is because, of course, it affects the patient's health. It causes so much of bleeding and causes severe anemia. Patient may end up having DIC. And as I said, finally may go into shock and even death, right? Also, if it is not tackled in the initial few hours or few minutes, then it can also add up to the patient's morbidity and the patient's hospital stay. Even if the patient gets cured of it and is out of the whole nightmare, even then the patient has got psychological trauma throughout her life. So how do we know that the patient has got PPH? this patient, even after her delivery, she will start complaining of abdominal tenderness. She will suddenly, sometimes the patient just collapses or she goes into shock. Sometimes you may find that there is increase in the abdominal girth because of the collection of the blood inside the uterus. Also, you'll sometimes find that the patient starts having systemic complications, like the patient starts having tachycardia, the BP goes down, and of course, there is vaginal bleeding, which is not stopped. And sometimes it will require tamponade and surgeries, which we'll look into in the coming slides. Now we know what are the degrees of shock, right? So how to how to know what step is to be taken for which area of PPH, right? So first of all, the body tries and to compensate the blood loss that is there in PPH. For example, if it is only 500 to 1000 ml of blood loss, in those cases, uh, most of the times there is not much change in the blood pressure, and there's only palpitation, dizziness, and tachycardia, right? So in this case, the body tries to compensate for the blood loss. But when it is a little more than the compensatory PPH, then it is around 1000 to 1500 ml of the blood loss, which is around 15 to 25% of the total circulatory volume. And the blood pressure, it goes slightly down, that is around 80 to 100 mmHg, the systolic blood pressure. And the patient starts complaining of weakness, sweating, right? When it is moderate, there's a little more blood loss, which is around 1.5 to 2 liters, which contributes to 25 to 35% of our total blood volume, which is a huge volume, right? Again, there's a severe fall in the systolic blood pressure, that is around 70 to 80. And there is restlessness, pallor, and oliguria for this patient. So that is why we all tell our residents to keep looking at the urine output, isn't it? That is why finding out how much is the urine output is very important. Not only the systemic values, but even this becomes a very important red flag sign to find out whether the patient has got PPH or not. Again, when it becomes very severe, which should not happen with any patient, but when it becomes very severe, then the whole systems, they start giving up. When it is more than 2000 to 3000, like around that much of blood loss, then the whole system gives up and there is a profound fall in the blood pressure and the patient just collapses. You can see that the patient's skin has gone white. She starts looking pale and there is anuria, there is air hunger, right? So this is the case wherein whole of the intensivist team should be called up. Then how do we diagnose PPH? Of course, there should be initial evaluation, like rapid assessment of the basic systemic status of the patient, finding out if the patient has got abnormal BP and abnormal pulse, like she has got tachycardia and hypertension or hypotension. And if there are signs of, then again, how to examine the patient? You need to find out if the patient has got any genital tract laceration, if there's any laceration down below, or the patient has got, as I just said, if there is increase in the size of the abdomen, which suggests that the bleeding is inside the uterus, right? So also you need to do the manual examination to find out if there is retained placenta, which can again end up with PPH, right? Again, you need to find out if the patient has got inversion of the uterus. So you also have to do the vaginal examination and find out if the uterus is coming down through the vagina, and also do an abdominal examination to find out if you can feel the fundus of the uterus and it is contracted. If there is a pimple on the fundus of the uterus, you have to think of uterine inversion, right? Then what all the laboratory investigations that we are going to do? Of course, we are going to do all routine, all the important things that are required, the basic things, and along with that, the coagulation study, the fibrinogen study, right? And we all have to look specifically at the hematocrit and the platelets. Now, what are the challenges that we face when we know that this is PPH? Right? So first thing is that you cannot measure PPH, isn't it? You can only estimate PPH. And that is also because you don't know how much the patient has lost inside if it is a concealed PPH specifically. And also there is alteration in the pulse and BP, and there is flabby uterus in atonic uterus. So there are too many things that you have to deal with when PPH happens. Most of the times what happens is there is delay in the diagnosis because we really don't know how much if the patient has got PPH, because every patient has got some or the other amount of bleeding after delivery. So sometimes we may just miss out. It just happens. So she may soak 1 or 2 pads, and we may not take a follow up of how many pads she has soaked. Also, we may not be able to estimate because we are only look at the blood loss. No, we cannot measure it. So we don't know whether this has crossed the danger boundary. Again, there are many cases of PPH that occur without any identifiable risk factor. Again, sometimes we may just over or underestimate it. What are the complications that happen? As I said, it causes a lot of anxiety. Sometimes it may even lead to depression after the delivery, right? Because she has to go through so much this doctors running around, she going pale, and then again sometimes ending up in ICU. So this may cause her trauma emotionally and may end up having postpartum depression. Again, there can be anterior pituitary ischemia with delay or failure of lactation, which we all know as Sheehan's syndrome, right? Again, there can be severe anemia, fatigue, blood transfusion may be required, which we always say that we need to keep it reserved. But when it is, most of the times, PPH is unpredictable. And in those cases, again, this can also delay the treatment procedure. Myocardial ischemia, dilutional coagulopathy, and sometimes even death, right? So what do we do? What are the stages of management of PPH? So this is something which every doctor who is into this field of obstetrics and gynec is, this has to be by heart, and this is something that they are really trained in. The skills and drills are taken for this thing. So I'm sure every doctor must be knowing on how to start with the treatment of PPH. So we'll just go through it. We all know that there are so many agents like oxytocin, carboprost, mesoprost, which take care of our PPH patients. Again, we also say that active management, like delaying in the cord clamping or performing the controlled cord traction, even that reduces or prevents the chances of having PPH. Again, there is, if we assess the uterine tone immediately and we keep an eye on PPH, we are aware that this patient may end up having PPH. We know the high-risk cases. Again, it reduces the chances of having postpartum hemorrhage, right? So vigilance, again, is a very important part of active management of third stage labor. So we all know that the uterotonics, which are given in the first initial minutes of a patient with PPH or to prevent PPH, like to have this contracted uterus, is the most important part as suggested by WHO also. So that is the most important part of preventing PPH, right? Now, what is the practice of prophylaxis of PPH? As we all say, prevention is better than cure, because then running around with the patient with PPH, we all know how difficult it is to cover up the patient. So how we can just prevent this PPH? One is finding out what is the HB of the patient. That shouldn't be missed at all. Sometimes it may happen, like with a lot of patients, we may even not check the clinical status of the patient. So it is always, first of all, important to find out what is the clinical status if she's looking pale. Of course, you should always get all the investigations done, and the hemoglobin being the most important part for PPH. identify if they are high-risk women, some patients who are having twins, some patients who have got history of precipitate labor, or these patients who are at risk of having PPH, you should be aware that you have to take measures and you should be keeping things ready in case she ends up having PPH again. Again, plan for institutional delivery, because most of the time, even out of India, there are midwives who take care of the patients who are in labor. Uh, in India, at least for now, we all know that most of the times the patients, they do go to the hospitals and get themselves delivered by the doctors, but there are still some villages or some rural areas wherein it is not easy for the patients to go to the doctor. So it is always very important that if the patient approaches you once and you know that she is at risk of having PPH, you should be counseling her, and even the PHC center should be counseling these patients, the high-risk patients, to have institutional delivery, wherein she may require a lot of multidisciplinary care, right? There should be strict vigilance of all the women in third stage of labor. Again, there should be active management of the third stage of labor, as we all know, after the delivery of the baby. This part, the active management of third stage of labor, becomes a very important part to prevent PPH. Examine the afterbirth, right? As a routine, sometimes we just end up taking out the placenta and just leaving it out in the kidney tray and not looking at it. So it is also very important whether you have removed the whole of the placenta. Also important to see if the placenta is looking normal, right? Again, you always should look at the patient even after the delivery. You should do examination, see if there is any laceration there, see if the patient is not bleeding abnormally. Okay, even that prevents the chances of PPH. Now, going to the uterotonics, we all know, as we were just talking about, is oxytocin, there is carbetocin, there's ergometrin, symptometrin, misoprostol, carboprost, everything. Most of these are the uterotonic agents, and these agents are routinely used to prevent PPH, isn't it? So when do we use these uterotonic agents? These are to be used in the very specific or very emergency, like the first few minutes are very important, as I just said. So they're used in the initial part of the prevention of PPH treatment. That is just after the crowning of the baby's head, or after the delivery of the anterior shoulder, or at the end of the second stage of labor, or just after the delivery of the placenta, within that much of time only. So after that, their efficacy also reduces and they're not much of use to us, right? So that is the time duration where we generally use the uterotonics. Of course, they are prophylactically used to prevent the PPH and also useful for the active management of the third stage of labor. So basically, the treatment that we all know and we all have been, told about, we all have been taught about, is the basic uterotonics. That is oxytocin, misoprostol, injectable prostaglandins, that is carboprost, right? Then again, there are prothrombotics like tranexamic acid or recombinant activated factor 7A, which again comes as a second line of treatment. Then there can be use of uterine tamponade. Also, there can be, if that doesn't work, you may have to take help of surgeries like uterine artery ligations and sometimes even obstetric hysterectomy, right? So when is the time when you should take action? Sometimes we are not aware when to start working. So it is really very important that you start getting alert when you see that the patient has lost around 500 to 1000 ml of blood. So in that area, you start keeping things ready that in case this patient ends up having PPH, you should be having all the uterotonics and all these things at hand, the prothrombotics. Even if the need of surgery arises, you should be calling up your colleagues, and the multidisciplinary team should be taking care of this patient once the alert line is crossed and she ends up with having a blood loss of more than 1 liter, right? And we all just spoke about the symptoms that the patient may have with the increase in the blood loss. Now, what are the challenges with the current therapy? Now, we all know that we keep on giving this oxytocin. Even then, most of the times, like it happens that we do take care of the high-risk patients. Most of the times when we all gynecologists, we do have a chat, we all always say that whenever there is a high-risk patient, she is taken care of. PPH always is unpredictable, and mostly it happens in patients where we are not sure, and which are normal patients, just have a primary patient, which she doesn't have any complication, without any not even thinking that she may end up having PPH. So most of the times it is very unpredictable is what we think. So why it happens and how do we cover this thing? So the basic things that we just spoke about, that checking every patient and having a protocol for every patient is very important. Again, these things like all the medications that we are using up till now, you should be seeing whether they are all working, because most of them, it may happen that most of them have lost the cold chain and they are not working also. So it is really very important to find out what uterotonics should be used and how do they work, right? So oxytocin, there's a need for appropriate training of the clinical staff to use oxytocin, because when we give them a proper dosage, they should be giving that much of dosage, right, of oxytocin. Again, there should be proper regular monitoring of the patient. We know that this oxytocin, it has got a shorter half-life, so we should see if this patient needs a uterotonic which has got a longer half-life. So we should be aware of this thing beforehand. Again, there's one more uterotonic, that is Symptomentrin, which we generally use, but we all know that it has got a disadvantage of elevated BP. Again, it can cause nausea, vomiting. Oral misoprostol again is one of the favorites, and we all know that even helps us, though it comes at the end, but even this has helped a lot of patients in prevention of PPH. So what is the problem with this? But that it causes increase in the incidence of vomiting, diarrhea, and we know that within 1 hour of pushing misoprostol, the patient starts shivering and having fever because of the side effect of increasing the temperature of the body, right? So all these agents, they do have some side effects, and that is why who recommends to use carbetocin? Why? Because who recommends the use of an effective uterotonic for the prevention of PPH during the 3rd stage of labor, and to effectively prevent the PPH, only one uterotonic should be used. So many times we end up putting oxytocin and then again carboprost and then again misoprost, all the things like so. So try to use something prophylactically which will reduce the need of the use of the other uterotonics. Again, the other uterotonics that are used in that, carbetocin has got a special role according to WHO now. Now, carbetocin is available at room temperature, right? So that is again there's this cold chain problem is just lost there, and there's not much important there. So this error doesn't happen, right? How it is better as compared to the other uterotonics that we use, or the oxytocin, which is the first uterotonic that we use, is one is that it is stable at room temperature. Another, it has got a shelf life of around 24 months, and it stays at around between 30 degrees centigrade to 75 and at 75% of humidity. It avoids, there's no need of maintaining the cold storage. Again, it is provided in vials, so easy to use. So that is again a very important thing of carbetocin, that it is stable at the room temperature, with specifically in a country like India, where there are huge changes in the temperatures. This is very important that we have something which has got which is stable in all the temperatures, right? Again, we know that carbetocin is actually a modification of a oxytocin structure itself. but it has got a prolonged half-life and it reduces the enzymatic degradation. Carbetocin is long-acting as compared to oxytocin. Again, it prevents PPH which is due to uterine atony, because PPH can happen because of many different reasons. So the one where atony is the reason, which is the most common reason for having postpartum hemorrhage. So it reduces the chances there. Again, what is the drug and dosage? It is 100 micrograms of carbetocin in 1 ml of solution that we give, right? How does it work? It binds and triggers, it binds the receptors that are there inside, which activates the phospholipase C, and it produces IP3 and diacylglycerol. Now this IP3, as we have all learned in our second year of MBBS when we were reading our physiology, it is important for free calcium, isn't it? So this IP3, it releases more of the free calcium, and this free calcium, it gets binding of this calcium to calmodulin. It stimulates the uterine smooth muscles and it causes its contractions and thus contracts the atonic uterus. Okay, so this is how it works. As we just said, we have to give a single IV dose of carbetocin, 100 micrograms, administered after the delivery of the baby or maybe after the delivery of the anterior shoulder. And it is meant, specifically, it is useful in prevention of uterine atony and in preventing the excessive bleeding because of the uterine atony. Okay, this we have seen that no cold storage is required. It has got good tolerability and it has got a longer half-life. Okay, there's a table here which shows the comparison of carbetocin and oxytocin, right? So the onset of action, so IV, it is around 1.2 minutes for carbetocin and the duration of action is 60 minutes. Half-life is 40 minutes only. For IM, it is a little more, but still comparably to oxytocin, it is still better, right? So onset of action for IM is 2.3 minutes and for duration of action is very long, that is around 119 minutes, right? For oxytocin, it is for IV, it is immediate effect. When you push it or when it is going through the IV, it is working. Once you stop it, it stops working, right? And the half-life is only 3 to 5 minutes. For IM, it is a little more, it is around 2.5 minutes it takes for the onset of action, but the half-life is still very less, that is 3 to 5 minutes, and the duration of action is only for 30 minutes. So when you compare these two, you always see that carbetocin has got a higher part as compared to oxytocin in prevention of PPH. A single IV injection of carbetocin, it achieves the uterine activity within 2 minutes and lasts approximately 1 hour. Carbetocin can increase the rate and force of spontaneous uterine contractions. So we have seen that this carbetocin is around 24-fold less potent than oxytocin at the vasopressin receptors, which are responsible for causing hyponatremia, which is again very common with oxytocin. So what happens is this oxytocin, it displays its structural similarity to vasopressin, and that is why there is a lot of water retention, right? Because of this water retention, it leads to disturbance in the sodium levels and can cause water intoxication, causing hyponatremia. So even that side effect of oxytocin is not there with carbetocin, and that is why it has got an upper hand over oxytocin. So there are so many trials that people have done, and it has been seen, out of which one of them is the WHO champion trial, which has been spoken about for a very long time. And now it said that carbetocin is not inferior to oxytocin, plus it has got so many advantages over oxytocin in efficacy also. Like in efficacy, they both are same, but otherwise for handling the drug and for the room temperature, it becomes much more easy to handle carbetocin as compared to oxytocin. Right, so this is the champion trial. And they have compared both of them. So it was a double-blind randomized trial, and they have seen that carbetocin and oxytocin, they have got same efficacy, but this is the trial, and the conclusion was that carbetocin was non-inferior to oxytocin for prevention of blood loss of at least 500 ml, or the use of additional uterotonic agents were reduced with the use of carbetocin. Okay, and so there are so many studies. I'll not go through most of the studies, but all these studies, they do suggest that carbetocin has got lesser side effects, and it is the efficacy same as that of oxytocin. Sorry. Okay. So these are all the RCTs which are showing how carbetocin and oxytocin were compared, and it was seen that carbetocin had the same efficacy as that of oxytocin, but much more comfortable to use. Okay, even in the high risk cases wherein the water intoxication was a very big side effect of oxytocin, even in those patients, this has shown to have a lot of efficacy because it doesn't have the side effects of having hyponatremia, right? So even in high risk cases, it has been seen that carbetocin has significantly reduced the risk of PPH. So we'll directly, they have shown that this carbetocin, it is more effective than, of course, it is more effective than the other uterotonics, which is symptometrin, which has got a side effect of having increasing the blood pressure. So of course, it is much more safer as compared to the other uterotonics. Then it has got the least side effects, as we all just said, that it has got less number of less amount of nausea, vomiting. Again, there are less chances of patients having hyponatremia. Also, it is more stable at room temperature. Patient has got less complications of shortness of breath and dyspnea as compared to the patients who were given oxytocin. Okay, so efficacy of carbetocin was checked against a lot of uterotonic agents, and it has been seen that carbetocin is effective as compared to the other uterotonic agents. It lowers the risk of PPH, it lowers the blood loss compared to those treated with symptometrin. It reduces the need of uterine massage, which is as compared to oxytocin. Also, it is seen that it is statistically, it is significant. There is significant reduction in the need of the other uterotonics. Like you don't have to keep the train of uterotonics going on once carbetocin is used for prevention of PPH on the very first hand. All these other trials, and carbetocin is being very widely used now by many obstetricians, and I have been using it also in my clinic, and I have been seeing that patients, I have to use a very little amount of other things like the uterine massage, and the vaginal bleeding is very less as compared to the other uterotonics when they were used. So when oxytocin was used, if there was around 500 ml of blood loss with the same kind of patient, the other patient showed very little blood loss when carbetocin was used to prevent PPH, with me at least. So the key messages, the key takeaways are: postpartum hemorrhage remains a clinical significant cause of maternal death, which we all know, and that is why WHO recommends the use of prophylactic uterotonics. This could reduce the PPH by more than 40%. Carbetocin is a synthetic long-acting analog of oxytocin, which was created by making several modifications in the oxytocin molecule itself, but a better oxytocin, right? Carbetocin is now available at room temperature. It is temperature stable, and that is why convenient to use. Carbetocin has got similar efficacy as that of oxytocin. Again, it has reduced the chances of having other blood loss. Also, it reduces the chances of taking using other uterotonics also. Again, the Champions trial, which said the same thing, that it has got the same efficacy and reduces the blood loss by at least 500 ml, compared with symptometrin, misoprost, oxytocin, carbetocin. It has got better. It is significantly better hemoglobin levels with patients after delivery. Also, there is low risk of hypertension, and also there is fewer adverse events with carbetocin. And that is why WHO, FCOG, FIGO, and the Australian Age Society, that is RNZ-COG. So all those, RANSCOG, they have recommended to use carbetocin for the management of PPH. So thank you very much for having me. That was my presentation. Stop my share.
Thank you very much, madam.
I
There
need
have
to
been
stop sharing the video.
there are few questions. With your permission, I will ask. You know, in your experience, do you feel the frequency of contraction or the intensity of contraction is more with carbetocin than with oxytocin?
The intensity is reduced, very much reduced, and there's more contraction of the uterus after the delivery. Like the uterus contraction is very high. Whenever you find the numbers, you get contracted uterus.
So carbetocin has got probably a higher intensity than oxytocin in your experience. You know? Yeah.
Higher intensity, but it has been said that the efficacy is the same.
Similar, yes.
Carbetocin I have never faced any that I have given carbetocin and the patient has got a flabby uterus. That has never happened.
Now, in this, now we know that PPH is common in patients for with uterine atony. Which of the factor in uterine atony PPH is more common? That is prolonged labor or multiple gestation or fibroid or recent placenta. Which one is it?
All of them. All of them.
Okay.
Yes, all of them, because there's a lot of distension of the uterus in these patients, like whether it is polyhydramnios patient, twins patient, or a prolonged labor patient. So all of them, they have got more chance of having PPH, and that is why we all should be knowing that these patients are high risk and should be aware of it and keeping things ready beforehand.
Correct. Like we say, always expect the unexpected. We don't know when that unexpected will happen and what way and form and shape.
Yeah, and that is very predictable with PPH, that
correct.
It is going to be unpredictable.
Correct. And suppose if someone has used oxytocin in antepartum for, say, dilatation, can we use carbetocin for prophylaxis?
Yes.
There's no. Now, suppose someone doesn't respond to carbetocin, what is your second line of
so if it so happens that carbetocin has not worked, we always go to the first line, that is oxytocin, and then start accordingly the oxytocin then. But most of the times it is like a lot of drugs together, because we know that the first drug has not.
Right.
So it starts with oxytocin going IV and giving carboprost and misoprost vaginally, and then carboprost IM. So the whole team now then starts working when.
We cannot take risk then. Yeah. That's correct.
Yeah. It is always better to go back to your theory books.
Yes, correct. Yeah. Is the cold chain really a challenge in our country?
Yes. Because most of the times we don't even know which drugs are to be kept in the fridge and which are to be kept outside. Because I've seen so many drugs which are to be kept at a low temperature. They're actually kept at room temperature.
Absolutely.
And the room temperatures vary so much in India. They are not like outside.
No.
That they are going to be less.
Even our OTs do not have a proper, cold chain. Yeah, that's another thing.
That's another thing. And that is why, because we have got untrained staff.
Correct.
Most of the times. So that is the main problem.
Absolutely. This is a big statement. Can we say that to use carbetocin prophylactically in every delivery to prevent PPH? It's a big statement. What do you feel about it?
I feel that carbetocin has worked and it is going to be the next drug in use. Okay, so that is going to be the next favorite of all the obstetricians.
Correct.
And also why? Because it is easy to use. But of course, we can actually use it in low risk patients, and we can
Correct.
also use it in high risk patients.
Absolutely.
So there should not be a problem to use it prophylactically for almost all the patients where there's and it doesn't have any side effect also. It's like most of the
Absolutely.
side
Yeah,
effects
yeah,
are,
yeah.
there's no problem. There should be no
There's
problem
no
actually.
unexpected thing. Yeah.
Yeah.
I mean, now this is more of a question for me. You know, with all these pluses, still Carbetocin has not climbed to the top. It's still struggling somewhere in between.
Yeah, so that is because we still have so many in the books when we
Yeah.
were taught.
Correct.
We have got oxytocin as the first line of agent, and we all doctors, we are very scared when we have to use a
I know.
new drug. You all know that we use it on the low risk patients first. We see how
Correct.
it works, and only then
Absolutely.
use it for the high risk patients. And that is why it will take time to come up, but it is going to be the next favorite. That is for sure.
It's so wonderful, madam. Thank you so much. You know, wonderful session, and thanks for answering all these questions. If there's something, we'll again come back to you. Thanks once
Sure.
again.
Thank you for having me. Thank you.
Yes. Thanks, everybody. Thanks, all the doctors.
Okay. Okay, so I'll leave now. Thank you so much.